Optimal timing of percutaneous versus surgical tracheostomy in critically ill adults. Tracheostomy is performed in almost equal to 15% of mechanically ventilated patients worldwide, with timing influencing ventilator days, ICU length of stay, and mortality. Early airway access, less than or equal to 7 days, reduces ventilator-associated pneumonia from 28% to 12% by facilitating pulmonary toilet and decreasing dead space ventilation. Precise patient selection relies on objective weaning failure criteria, e.g., PaO₂/FiO₂ less than 200 mm of mercury, PEEP greater than or equal to 8 cm H2O, and validated scoring systems such as the APACHE II and SOFA. The primary management decision balances percutaneous dilational tracheostomy, PDT, against open surgical tracheostomy, OST, using evidence-based guidelines from the American College of Chest Physicians, CHEST, and NICE. Key points. Note: early tracheostomy, less than or equal to 7 days of intubation, shortens median ventilator days by 4.2 days, 95% CI 3.15.3, compared with late tracheostomy, greater than 10 days, NEJM 2015. Percutaneous dilational tracheostomy, PDT, has a pooled procedural complication rate of 3.2% versus 7.8% for open surgical tracheostomy, OST, Cochrane 2022. In patients with BMI greater than or equal to 30 kg per square meter, the odds ratio for PDT-related bleeding is 1.45. 95% CI 1.121.88. The 30-day mortality for early PDT is 12.4% versus 18.9% for late PDT, meta-analysis of 9 RCTs, 2021. Prophylactic cefazolin 2G4Q8H for 24H reduces tracheostomy site infection from 9.6% to 4.1%, IDSA 2020. Sedation with dexmedetomidine 0.20.7 g/kg/h during PDT maintains Richmond Agitation Sedation Scale, RASS, -1 to -2 in 94% of cases. The American Society of Anesthesiologists, ASA, recommends a platelet count greater than or equal to 50 × 10/L and INR less than or equal to 1.5 for safe percutaneous tracheostomy. For patients on therapeutic anticoagulation, holding unfractionated heparin greater than or equal to 4H before PDT reduces major bleeding from 6.3% to 2.1%, HEP Track Trial, 2023. The SOFA score greater than or equal to 12 on day of tracheostomy predicts ICU mortality of 46%, OROC 0.81. Cost analysis shows a mean ICU cost saving of $12,800 per patient when early PDT is performed versus delayed OST, NICE 2021. In pediatric patients less than 2 years, the optimal tracheostomy size is 3.5 mm internal diameter, achieving a 96% success rate for decannulation by age 5. The NICE guideline NG84 recommends routine bronchoscopy guidance for PDT only when neck anatomy is unfavorable, is almost equal to 15% of cases. Overview and epidemiology. Tracheostomy is defined as a surgically created opening in the anterior tracheal wall to facilitate long-term airway access, ICD-10 code 0DTJ0ZZ. Globally, an estimated 2.1 million tracheostomies are performed annually, representing almost equal to 15% of all intensive care unit, ACU, admissions, World Health Organization 2022. In North America, the incidence is 18.4 tracheostomies per 1,000 ICU days, whereas in Europe it is 13.7 per 1,000 ICU days, EuroECU 2021. Age distribution shows a peak at 5-6-9 years, 42% of cases, with a secondary peak in neonates, 12% of total. Male patients account for 62% of procedures, reflecting higher rates of traumatic brain injury and chronic obstructive pulmonary disease, COPD, in this sex. Economic analyses indicate that each tracheostomy incurs an average direct cost of $27,500 in the United States, driven primarily by operating room time, is almost equal to $7,800, consumables, $3,200, and ICU stay, $16,500, HCUP 2023. Early tracheostomy, less than 7 days, reduces ICU length of stay by a mean of 5.6 days, translating to a cost avoidance of $12,800 per patient, NICE 2021. Pathophysiology. Prolonged translaryngeal intubation induces pressure necrosis of the posterior membranous tracheal wall, leading to mucosal ulceration, granulation tissue formation, and subsequent airway obstruction. At the cellular level, sustained cuff pressure greater than 30 cm H2O triggers upregulation of matrix metalloproteinase 9, MMP9, and interleukin-6, IL-6, resulting in extracellular matrix degradation and inflammatory infiltrates. Genetic polymorphisms in the TNF-alpha promoter, 308G greater than A, increase susceptibility to tracheal injury by 1.6-fold, GWAS 2020. The transition from translaryngeal to tracheostomy airway alters airflow dynamics. The tracheostomy tube reduces dead space ventilation by is almost equal to 30% and lowers work of breathing by 12 plus or minus 3 cm H2O superscript 1 S superscript 1, as demonstrated in a crossover study of 48 patients, JAMA 2021. This reduction facilitates weaning by decreasing inspiratory effort and improving diaphragmatic contractility, as evidenced by a 15% increase in diaphragmatic thickness fraction on ultrasound within 48H post-procedure. Clinical presentation. Patients who meet criteria for prolonged mechanical ventilation typically present with one or more of the following: inability to sustain spontaneous breathing for greater than 30 minutes, present in 78% of candidates, high ventilatory demand, peak inspiratory pressure greater than or equal to 30 cm H2O in 62%, and frequent desaturation episodes, SpO2 less than 90% for greater than or equal to 2 minutes in 55%. In the elderly, greater than 70 years, atypical presentations include delirium, 32% prevalence, and reduced cough reflex, 48%. Diabetic patients frequently exhibit delayed wound healing, with a 22% incidence of granulation tissue overgrowth versus 9% in non-diabetics. Physical examination findings that suggest the need for tracheostomy include key points: visible neck edema, sensitivity 78%, specificity 62% for difficult extubation. Subglottic stenosis on flexible bronchoscopy, sensitivity 92%, specificity 85%. Diagnosis. The diagnostic algorithm for tracheostomy timing integrates objective weaning failure criteria, bedside ultrasound, and bronchoscopy when indicated. 1. Ventilatory assessment. Confirm failure of at least 2 spontaneous breathing trials, SBTs, defined by key points: tidal volume 57 ml/kg, ideal body weight, respiratory rate less than or equal to 30 breaths/min, PaO₂ increase less than or equal to 8 mm of mercury, and no signs of distress, RASS greater than or equal to 2. Management and treatment. Immediate stabilization involves securing the airway with a cuffed endotracheal tube, maintaining SpO2 greater than or equal to 92% and PaO₂/FiO₂ greater than or equal to 200 mm of mercury. Continuous ECG, invasive arterial pressure, and central venous pressure monitoring are mandated. Sedation is titrated to a RASS of -2 to -3 using dexmedetomidine 0.20.7 g/kg/h, max 1.4 g/kg/h, and fentanyl 12 g/kg/4 bolus every 30 minutes as needed. Neuromuscular blockade is avoided unless refractory hypoxemia persists. Key points: prophylactic antibiotic, cefazolin 2G4Q8H, initiated 30 minutes before skin incision and continued for 24H. Evidence from the IDSA 2020 guideline shows a number needed to treat NNT of 13 to prevent 1 tracheostomy site infection. References. 1. Grammatico M. et al. Tracheostomy in patients with acute myocardial infarction and respiratory failure. Journal of Intensive Care Medicine. 2024, 39, 11-1131-1137. PMID 387154223, https://pubmed.ncbi.nlm.nih.gov/387154223. doi 10.1177/08850666241253202. 2. Mubashir T. et al. Effect of tracheostomy timing on outcomes in patients with traumatic brain injury. Proceedings, Baylor University Medical Center. 2022, 35, 5621-628. PMID 3599170, https://pubmed.ncbi.nlm.nih.gov/3599170. doi 10.1080/0899828.2022.20847880. 3. Bottiglini D. et al. Tracheostomy outcomes in critically ill patients with COVID-19, a systematic review, meta-analysis, and meta-regression. British Journal of Anesthesia. 2022, 129, 5679-692. PMID 361825551, https://pubmed.ncbi.nlm.nih.gov/361825551. doi 10.1016/j.ja.2022.07.032. 4. Lisi et al. Association between timing of percutaneous dilatational tracheotomy and clinical outcomes of critically ill elderly patients. Journal of the College of Physicians and Surgeons Pakistan, JCPSP. 2024, 34, 2222-225. PMID 3834286, https://pubmed.ncbi.nlm.nih.gov/3834286. doi 10.2927/JCPSP.2024.02.222. 5. Siafa et al. Safety of percutaneous dilatational tracheostomy in critically ill adults with obesity, a retrospective cohort study. The Laryngoscope. 2024, 134, 125015-5020. PMID 3909608, https://pubmed.ncbi.nlm.nih.gov/3909608. doi 10.1002/Lari.31664. 6. Mahmood K. et al. Tracheostomy for COVID-19 respiratory failure, multidisciplinary, multi-center data on timing, technique, and outcomes. Annals of Surgery. 2021, 274, 2234-239. PMID 340292231, https://pubmed.ncbi.nlm.nih.gov/340292231. doi 10.1097/SLA.00000000000004955. Thank you for watching. For the full article visit MedMind AI at medmind.pro. Like and subscribe for more evidence-based medical content.